Okay, my last case is of a 34-year-old woman with end-stage kidney disease. She started dialysis in 2018 at the age of 31. She has frequent admissions for so-called dialysis non-adherence, which unfortunately is actually due to her not having childcare during her scheduled dialysis shift. And initially, her presentation was actually due to nephrotic range proteinuria in 2007. And at that time, she actually did require, she had AKI requiring dialysis, came off dialysis briefly, but then was started on dialysis again, as I mentioned. She did not have a biopsy at the time of her presentation or at any point. She had a broad workup for glomerular disease and had a variety of negative serologies. In her medical record, chronic kidney disease that are listed as the reason for her kidney disease, including secondary FSGS from obesity, hypertensive nephrosclerosis, and quote-unquote medication non-adherence. The patient is African American, and her family history is notable for her mother also being on hemodialysis at a very young age. So to talk a little bit about APOL1 renal risk variants, there's a region on chromosome 22 that contains genes encoding the MYH9 gene for myosin heavy chain and apolipoprotein L1. And the last exon of APOL1 has two common variants called G1 and G2, which are in tight linkage with MYH9, and these associate with higher renal risk. High-risk variants, which are either G1, G1, G2, G2, or compound heterozygotes who are called G1, G2, have higher risk, particularly of these conditions, including HIV-associated nephropathy, FSGS, and CKD attributed to hypertension based on case control studies with up to 29-fold or 7 to 10-fold increased risk. The population estimates of these variants are that at about 30 to 35% of individuals with recent African ancestry carry at least one risk allele, and it's thought that at least 12 to 13% carry two high-risk alleles, although only about 20% of these individuals will have overt kidney disease. So we did pursue genetic testing in this patient in an effort to better understand her disease and her need for kidney dialysis at such a young age, and to also, to some degree, help the patient to understand why this had happened to her, and to try to combat some of the language sort of used in the medical record about her non-adherence, her supposed non-adherence, which she had been sort of labeled with. So indeed, she had two G2 increased risk alleles, indicating that indeed she had APOL1 mediated kidney disease. And her mother underwent the genetic testing as well for the same reason and was found to actually have a G1 and a G2, meaning that the patient clearly inherited the G2 from her mother and that her father is either a heterozygote carrier of G2 or may have either just one copy or another copy of non-higher renal risk variant. Unfortunately, we are not able to test her father to know for sure, but he definitely had at least one G2. So what does this information do for our patient? She's already on dialysis at a young age, so it's not like we have this genetic information and can predict that she's going to have disease progression or be at higher risk per se. She does not have diabetes. There has been an observation that there might be increased survival on dialysis due to reduced subclinical atherosclerosis development in individuals who have the renal risk variants of APOL1. And this was evaluated in a population of about 400 dialysis patients in whom APOL1 gene status was available. And here you can see that the non-diabetic patients with 2 risk variants actually had a statistically significantly longer survival on dialysis. There have also been conflicting results from other studies, but there is some scientific underpinnings to this that would suggest that there is less aggressive atherosclerotic development as a result of these renal risk variants. So how would this affect her ability to be transplanted one day, since she is so young and it is extremely difficult for her to undergo dialysis? So it's estimated that about 23% of first-degree relatives of Blacks with non-diabetic kidney disease are projected to have 2 risk variants. Barring potential donors with 2 renal risk variants could have numerous disadvantages, including further reducing access to living donation among African Americans and potential psychological distress from having a diagnosis of this risk and not necessarily having kidney disease. It might be appropriate eventually to get to a point where we actually have a method for assigning a threshold for age and assessing a risk for a second hit among 2 renal risk variant carrying individuals. And I'll talk a little bit more about what I mean by a second hit in a couple slides from now. So, considering that if 2 renal risk variants in donors really does accelerate progression of disease to end-stage kidney disease, it might be reasonable to exclude those with 2 renal risk variants from donating a kidney. And actually, a very small study does show about a 10% rate of end-stage kidney disease in living donors with 2 renal risk variants, although this is currently the subject of larger evaluation in the APOLLO consortium, as alluded to by Dr. Rastogi, of which our centers are a part. So this patient was eager to have more understanding of her disease, as I had mentioned, since she was so young, and we discussed the pros and cons of genetic testing. But what are community member views on APOL1 testing? This study was conducted among 39 participants who were representative of a African American patient population in a variety of cities in 2019. And this group expressed unanimous support for testing so-called cadaveric or deceased donor kidneys that were being transplanted. There was near unanimous support for offering testing to living donors with counseling, but sort of dispute about whether it should be mandatory or not. And notably, 90% actually opposed barring living donation from individuals with 2 renal risk variants. 64% endorsed universal testing for Black patients, although this was sort of further delineated into only about 21% favoring offering the test to those with CKD risk factors, and 10% thought that only patients with signs of CKD should be offered testing. So I mentioned the second hit that is thought to be the precipitant for kidney disease in individuals with 2 renal risk variants of APOL1. And here is a schematic describing what that means exactly, in that podocytes with APOL1 high-risk phenotypes is the first hit, and then a second hit actually is thought to be mediated by increased interferon levels. And this can be due to viral infections, for example, HIV, as has been described, in terms of HIV-associated nephropathy, and also various drugs or inflammation such as lupus. And this second hit is what precipitates the cellular swelling, mitochondrial damage, and then downstream effects of cellular disruption that eventually leads to podocyte effacement, albuminuria, proteinuria, and inflammatory response that leads to the phenotype of APOL1 associated FSGS nephropathy or HIV associated nephropathy, seen as collapsing glomerulopathy on biopsy. So it's 2021, we're still dealing with COVID-19, and it's notable that it has indeed been shown that those with an APOL1 high-risk genotype can be susceptible to a second hit from COVID-19. So here is a series that was published very recently, given our ongoing battle with COVID-19, which shows features of COVID-19 glomerulopathy in APOL1 high-risk genotype patients, including collapsing glomerulopathy and foot process effacement. So to get back to my original take-home points, genetic testing may reveal information that seemingly conflicts with other clinical information about risk of rapid progression in ADPKD. Genetic testing may reveal alternative diagnoses, as in our second case. And I think that the future will show an evolution in terms of how we use APOL1 genetic testing, but we may eventually be able to help identify at-risk individuals, perhaps understand better how to attenuate effects of the so-called second hit, but uncertainties still exist regarding clinical implications. Thank you so much, and I know we'll get questions in the panel discussion, but you can also email me anytime at pkd@ucsf.edu. Thank you so much.